Hello, my name is Sariah Islam, and this is my Applying the Evidence presentation for Nursing 400. I will be presenting my analysis of a research article investigating the impact of contraceptive counseling in primary care settings. My PITCO question is, in women of childbearing age who seek medical care within a primary care clinic located in Oregon, would introducing a universal screening of asking the question, would you like to become pregnant in the next year, compared to not asking this question, reduce the rate of unintended pregnancies within Oregon? This pie graph represents recent reports of unintended pregnancy occurrence published by the CDC in 2012. It is estimated that 51% of all pregnancies that occurred within the United States between 2006 and 2010 were unintended. If this is not shocking enough for you, did you know that every woman living in the United States can expect to have 1.48 unintended pregnancies in her lifetime? In other words, practically every single woman living in the United States is personally affected by unintended pregnancy at some point in her life. The occurrence of unintended pregnancy seems to be particularly concentrated among women for whom it is likely to be the most disruptive and who would be less likely to have the resources necessary to deal with the consequences of becoming pregnant unintentionally. 2/3 of unintended pregnancies occur among women who are less educated, teenaged, married, or low income. As a result of this lack of resources, these women are much more likely to require a variety of publicly funded programs to assist in all of the expenses that come with having a child. The average cost of government spending per publicly financed unintended pregnancy is roughly $10,000. This translates to an estimated $12 billion each year being spent on publicly financed medical care for women who experience unintended pregnancies and on infants who were conceived unintentionally. After accounting for the fact that some of these pregnancies are mistimed while others were altogether unwanted, the estimated amount of savings that would result from preventing all unintended pregnancies ranges from $4.7 to $6.2 billion per year. Keep in mind, these figures include only the cost of health care needed throughout pregnancy, labor and delivery, and during the postnatal period. So why is it that 51% of pregnancies are unintended? The answer to this is multifaceted. Approximately 55% of unintended pregnancies occur when no method of contraception was used in the month of conception. More than 40% were conceived in a month where a contraceptive method was used inconsistently or incorrectly. So why is it that women are not using contraception as reliably as needed to prevent unintended pregnancies? Previous research has found that poor contraceptive use can be attributed to a wide variety of factors. The most frequently cited reasons are difficulty accessing contraceptive methods, misperception of their personal pregnancy risk, the unpleasant side effects of a current contraceptive method, infrequent sexual intercourse, and misinformation about how to properly use a contraceptive method. You may have noticed that many of these factors could possibly be remedied through preventative counseling. It was not until recently, however, that the idea of increased communication between primary care providers and their female patients about contraception has been identified as a potentially important factor in promoting effective contraceptive use. Despite this, the impact of contraceptive counseling in primary care on women's contraceptive use remains inadequately researched. The bottom line here is that despite unintended pregnancies being highly preventable with a wide variety of birth control options, as well as having many negative consequences on the overall well-being of our society, they still affect practically every woman living in the United States at some point in her life. But unlike other preventable healthcare-related problems, if prevention is an issue not taken nearly as seriously as it should be. In my search for existing research that addresses my PITCO question, I quickly discovered that there is very little that addresses this topic. I searched in many different databases using a plethora of keywords, and I finally did come back with a few articles. However, many of them did not very closely match what I was inquiring about. The one article that I was able to find that closely matched what I was inquiring about was this one that I will be discussing. It is titled The Impact of Contraceptive Counseling in Primary Care on Contraceptive Use, and it was published in the Journal of Internal Medicine in 2011. Here's the APA citation in case you wanted to look it up. I found it on Medline using the keywords contraceptive counseling and primary care in my search. It can be categorized as a level 6 on the evidence pyramid because it is a single correlational predictive study, which is a type of descriptive study. In my appraisal of this article, I used the general quantitative study appraisal tool found in our textbook, as well as some of the relevant questions from the cohort study appraisal tool because many of the study's basic elements are similar to that of a cohort study design. This study evaluates the association between contraceptive counseling provided by primary care providers and patient contraceptive use. Female patients aged 18 to 50 years of 4 primary care clinics were asked to participate in a survey 7 to 30 days after attending an appointment. The survey assessed pregnancy intentions, receipt of contraceptive counseling, and use of contraception at last sexual intercourse. Based off of the data collected, the researchers concluded that participants who received contraceptive counseling from a primary care provider were significantly more likely than those who did not to subsequently report use of hormonal contraception the last time they had sexual intercourse. Why was this study done? As I previously mentioned, this study's design is correlational predictive. Correlational predictive studies predict if one variable that occurs earlier in time predicts another variable that occurs later in time. The formation of a strong relationship in correlational predictive studies frequently lends support for further intervention research of the independent variable in future studies. The researchers of this study state that the study's purpose was to provide more insight into the relationship between contraceptive counseling provided in primary care settings and the patient's contraceptive use. They then further specified to assess whether receipt of contraceptive counseling at the most recent visit to a primary care clinic is associated with a greater likelihood of self-reported contraceptive use at last sexual intercourse. Therefore, the overarching purpose of this study is to contribute to the limited body of research suggesting that contraceptive counseling in primary care is important in preventing unplanned pregnancies to lend support for future interventional research of contraceptive counseling in primary care setting. What is the sample size? All women who visited one of the primary care clinics involved in the study during its 19-month length were invited to participate, and a total of 1,965 of these women responded to the survey. That is only 19% of the total women who were asked. After excluding 1,195 of these women for not meeting the study's specific participant criteria, the final sample size was 770 women. Was this sample representative of the population being studied? Using a sample always brings about a risk of inaccurate deduction when generalizing the results of a study to the reference population. This is termed sampling error and occurs when the averages of variables within the sample are not identical to the corresponding averages within the reference population. A majority of the 770 women included in the sample were Caucasian and had some amount of higher education. Although the reference population of the study is not explicitly stated, it is implied to be all women living in the United States aged 18 to 50 years who have any risk of unintended pregnancy. It is reasonable to assume that these demographics are not comparable to that of the reference population. This is of particular importance because women with less education and of a minority race are at a heightened risk of unintended pregnancy. As such, it can be concluded that this sample is not representative and that sampling error likely exists. External validity refers to the degree of generalization of the study's conclusion. Because of the demographics of this sample is not comparable to the reference population, the study's external validity is questionable. Are the measurements valid and reliable? The survey used was 75 questions in length and could be completed by telephone or on the internet. It assessed various demographic characteristics such as age, race, marital status, income level, pregnancy intention, receipt of contraceptive counseling at appointment, and use of contraception at last sexual intercourse. The question used to assess pregnancy intention was deemed to be valid and reliable in a prior study. To assess whether or not participants received contraceptive counseling, they were asked this as a yes or no question. The quality of counseling was assessed by asking the participants to rate their satisfaction with the counseling they received using a 4-point interval scale ranging from very satisfied to not satisfied. There is no report of validity testing of these questions. As such, they cannot be deemed valid or reliable. The use of contraceptive counseling at last sexual intercourse was assessed by asking this as a yes or no question. In addition to not being tested for its validity and reliability, this measurement has significant reason to be doubted because the participants were not asked to provide a date of the last time they had sexual intercourse. Therefore, it is unknown if it occurred before or after the appointment in question. The researchers explained that previous research has shown that on average, women have sex at least once a month, and they used this finding to presume that most participants were likely referring to a sexual encounter that occurred after the appointment, since surveys were completed up to 30 days after the appointment. However, the researchers also mentioned at another point in the article that surveys were completed on average 9.5 days after the appointment. Because this is a major variable of the study, this calls into question the internal validity as well as the reliability of the study. How was the data analyzed? Multivariate logistic regression was used to analyze relationships between contraceptive use during participants' last sexual intercourse and 3 predictor variables: receipt of any contraceptive counseling, receipt of contraceptive counseling regarding specific contraceptive methods, and quality of the counseling received. Multivariate logistic regression is a type of statistical analysis that is used to predict the probability of 2 or more variables predicting another variable. And as I previously mentioned, the study found that receipt of contraceptive counseling from a primary care provider is highly associated with use of hormonal contraceptive use during the last sexual intercourse. Overall, I found this study to be adequate in providing some new information that may be useful to base further interventional research off of. It does have quite a few limitations, but because its purpose was not to change practice by itself, but to rather provide some associative data to stimulate further research, I believe that the limitations are not as detrimental to the study's validity as they would be if the study was one that its purpose was to stimulate practice change by itself. This topic is very important, and I believe that with enough research, it will eventually be proven that contraceptive counseling in primary care settings is a great way to prevent unintended pregnancies. However, because it is rather low on the evidence pyramid and provides only correlational evidence with many limitations, this article is not likely to independently bring about practice change. According to the Iowa model, if there is not a sufficient evidence base for a possible practice change, more research needs to be conducted on the subject before changes in practice can be implemented, which is where I believe that research on this topic currently stands. So that concludes my presentation. Here is a list of all the references that I used in creating this presentation if you want to take a look at them. Thanks for listening. Bye.